recording.
Wonderful. Thank you so much, Jeannie.
You're welcome. Well, I really want you to help me out because I'm a little, like, it'd be fun to do together.
Yes, absolutely. Right. Welcome, Patrick and Michelle. We're all here now. Yay. Welcome everyone who's watching us. We're very excited to share on the Beyond the Medicine channel this incredible group of people. Patrick and Michele Fishley are up in Calgary, Canada now, right? Calgary, technically, yes. Okay, cold place. And Jeannie Fontana is in Los Angeles, California, and I'm down here in Mexico. And I love everybody here and wanted to have an opportunity to have these incredible professionals, both in the medical field, but also the psychedelic field, come together and talk all things Iboga and Ibogaine. So get questions answered, talk about some of the myths and interesting dialogue that's going on these days around Iboga and Ibogaine because of legislative shifts and just interest. And I wanted some skilled professional voices to have a conversation. So Patrick, Michelle, would you like to introduce yourselves and share a bit about your background and what brings you here?
Sure. So I'm Patrick, and I was a critical care nurse for 30 years in the multi-systems ICU and emerge departments and trauma bays. Did a lot of extensive training there. My wife of 18 years or plus with the acute care settings from emerge to medical, surgical, addictions, mental health as well. So we bring that with us, and we saw a lot of things that were shortcomings in that modalities, right? We were like a quick fix, when something happened, we had a quick fix for things with their medical system, but people weren't truly being healed, or problems weren't really going away or being solved. And so about 12 and a half years ago, we were introduced to work with, as professionals, with Ibogaine to help the downtown east side of Vancouver with the addictions. So we started with that and saw a lot of real efficacy with that modality. And of course, Ibogaine is the one alkaloid of over 100 alkaloids of the Iboga tabernanthe plant. So we started with that and saw a lot of good results. A couple of years into that, we were introduced to the traditional format, so to speak, using the whole plant, and we saw the effects were like tenfold or more because of all the other supporting alkaloids that were within that plant as well, used for addictions, not just substance addictions, but addictions of the mind, and depression and anxiety, PTSD and traumas, and injuries. So we worked with that a lot. And, from there, we had a movie Dose, the first Dose movie we were in at our clinic. And so that was with us working with a young lady. And then, we held retreats for many, many years, and going to Africa, every year for a few years, doing initiations, getting more and more training, a real in-depth understanding of what the tradition is around this medicine, and and why it is, and being able to really we want to really like marry both the traditional and the conventional medicine together. And that's the way it should be for the new person here that's out today in today's world. We need to have that marriage of both. And then
we have during one of our trips to Gabon, we were given a very clear message that we needed to create more community. And so we started an online integration and preparation community. And within that, we do our best to prepare people for our retreats, but it's open to anybody going anywhere. But also to support them after, because we realize that that's what the medicine shows us and teaches us, is like its impact is really understood and cemented in when they go home, like after the retreat. You know, the retreat's just like the tip of the iceberg, like literally just the tip. So, yeah, so we've been working on that the last couple of years to let it become what, you know, best serves the people that come to our retreats, which I think, you know, is helpful for anybody going to any Ibogaine or Iboga center. So, yeah.
And
That's
just
an
for
event.
awesome, awesome. And just for context for people who have never heard of these medicines, why would you go to Gabon? What's in Gabon?
And where is it?
Yeah. Gabon is in Central West Africa, just under the Congo. So actually the Congo, the bottom tip of the Congo is half of Gabon. And it's where Iboga comes from. It's where, you know, the tradition that surrounds and supports Iboga is. And so it's a beautiful country that is filled with this ancient sort of wisdom of connection to the earth and to spirit.
Oh, love it. Thank you so much.
Mm-hmm.
Jeannie, welcome. Would you like to share why you're here and who you are?
Yes, and thank you for including me. And it's delightful to meet Patrick and Michelle. Thank you, Kim. For those who are watching, I am on my Peloton bike because I believe sitting is the new smoking, and it's something that I live by. So I view myself as a frontier wave surfer. Catching the waves between the unknown and the known, focused on medical therapeutics, unmet medical needs. I've been blessed in my life to be I call myself a modern day explorer. And the ecosystem that I play in is in healthcare. So I've had decades of experience that have brought me to this moment that those that are interested can look back, or maybe it'll come up in conversation, except that I find that I'm good at identifying novel therapeutics that come in that have a big impact, that are based with a new paradigm oftentimes. And it was something that I think that can meet an unmet need. And I think mental health issues in our country are truly at epidemic proportions and alarming across all generations. So during the pandemic, when I had time to reflect and readjust, and I'm sure we all did, I started reading. I like to read things that capture my attention, capture my life force, my energy, my curiosity. And it was when I had the time to finish Michael Pollan's book, How to Change Your Mind, that really, really captured my interest. And I started researching and exploring. I came to the space with a strong bias against psychedelics. I was raised in the 60s. I was immersed in the Cultural Revolution, although didn't participate in it. And honestly, I was quite scared. LSD and the people that I grew up, I'd look at them and like, that's, I just didn't understand. So that when I was reading and learning more about it, I thought, wow, to help the veterans suffering from PTSD and help depression, anxiety, and obsessive compulsive, and all these different applications, it made me skeptical at first. And that I kept on reading and reading and reading. I'm like, whoa, there's something here. And I had the luxury of listening to podcasts and watching films and reading books. And I became very interested myself in the self-discovery, exploration of self, as true to my exploratory, curious nature. And then had to, I wanted to try, but I was afraid, and not only afraid, it was illegal, a Schedule I drug, and what to do about it. So I had to figure that out, which I did, and was grateful because after about
She froze.
Oh, okay. I wasn't sure if I froze or who was freezing. She's
Yeah.
Oops. Well, I will, I'm sure she'll be back soon, but in the meantime, I will just really quickly introduce myself for folks who have not met me, or this is the first time you're at my channel.
I
There
don't
she
know.
is.
I don't know what just happened. That's never
That's
happened to me
okay.
before.
That's okay. Technology.
I've never had that.
Please go on, and then I'll introduce myself. Go for it. We heard that you're an Uber explorer.
Oh, just that funding is needed in this space to funding for research, continual research for clinical trials, of course, for training of therapists and having some oversight, regulation, standards of care, quality of care. Access is important. They wanted to make access. And all this comes down to money. And I was involved with a state initiative in California where I've been helped support bringing stem cells, at the time embryonic stem cells, to what we now refer to as stem cells. I was lucky to be able to build what is now the regenerative medicine industry, really born on very good research, basic research on human embryonic stem cells. So applying that same model to building the psychedelic ecosystem to support research, training, education, access for mental health using psychedelic assisted therapy. So bringing it to the public in a safe, responsible, and ethical way. I think I'll stop there.
Thank you so much. Thanks, Jeannie.
Okay.
I will fill in a few details. Patrick and Michelle are incredible healers, and I say that with an interesting caveat of what we consider to be healers versus some of the Western thoughts. Their presence allows for your own healing, and I personally sat with them 5 times, and I love them dearly, and had the experience of the Iboga plant. And Jeannie is also a little modest. She raised $3 billion for stem cells, or was part of that program. Just saying. She's done a few things. Also was a medical doctor for 20 years in palliative care. Is that right?
No, but it's okay.
I don't introduce people because I mixed up the details. But you're a medical doctor early in your career.
Let's just say I'm very well trained. I'm very well educated. Yeah.
Awesome. And for those of you that are new to my channel or just haven't seen or just brand new to this topic, I'm Kimberly Adams. I'm originally from California and was part of the Decriminalize Nature team that created the legislation that moved throughout the country to help support access. Boy, we didn't know what we were doing at that time, but that's okay. The things that have unfolded since 2017. I started early in my career in psychology, and all of my professors in my school had all been part of the first wave of psychedelics, and I thought that's what psychology was. Psychedelics that explored consciousness. I was super wrong. But I had an opportunity to hear about the first wave of the research and experience from back then, and it's made such different twists and turns in our current legislative space, therapeutic space, and definitely in the medical system. So the folks like Patrick and Michelle who have that traditional experience really lend a beautiful voice because they have true experience with the medicine itself. And then Jeannie has this incredible connectivity to all of these amazing people who can get some of these concepts seen and heard, I think, in a place that something could happen. So that's why I really wanted everybody to get here today and chat. And really this conversation started because Jeannie said, hey, I've got some questions about Iboga and Ibogaine. who can I ask? And I was like, I know some people. So I'm excited to, if we could start with what it is and how it's a little different than what we call a psychedelic these days, and why. That would be really helpful, Patrick and Michelle, if you could share Iboga and Ibogaine. Why is it not technically a psychedelic, and what is it?
Okay, well, so it's still classed as a psychedelic, but it's not a true hallucinogenic. So this classification for the Tabernacle Iboga is a neurogenic, right? Just to walk in the dreams or to create dreamscaping and such like that. So it has a real ability to ground us. So in as much as it can take us out to places far beyond our imagination in our cosmic fields, you know, it's really good at that. Its real purpose is to ground us and connect us with us. It's a medicine of the mind. So it's all about what goes on here, not so much what goes on out there. And in fact, what goes on out there is in direct correlation with what's going on in here, you know, because it's really about us. It's not a cookie cutter type of psychedelic, whereas, you know, a lot of these other ones that contain DMT, you know, there's a kind of a cookie cutter, like if you take mushrooms, you're going to do this or see sacred geometry or this and that, or you can have these different DMT experiences. With the Iboga, because it's neurogenic, every time it's deeply personal and deeply intuitive to what you need. And it's going to show up how you innately need to see it, which for Jeannie is going to be different than myself, and for Kim or for Michelle. And rightly so. And why wouldn't it be? It's, you know, it's very personal. So that's the big part between that, with that part of it. The difference between Iboga and Ibogaine is like Ibogaine is just the one alkaloid. And that's through a process of taking everything else, extracting everything out. And, you know, it's very psychoactive, and it's been used for a lot of things. Mainly, they found it for addictions in 1962. It helped. It just kind of came around like Wellbutrin and Zyban. You know, all the doctors, people with Wellbutrin were coming back, and all of a sudden, like, well, all my clients aren't smoking anymore. Let's make this Zyban and let's market it. So it has a real marketing factor and a niche for interrupting addictions. Now, that being said, there's Ibogaine, of course, inside the whole plant. So it works very well for addictions as well. Also, we prove that a lot in our long-standing retreat center in Vancouver. When we were doing the movie Dose and other stuff, we were using only, you know, the full plant of Iboga, and it works really well for that. But it does so much other things that are so important, because with the interruption of addiction and withdrawals, well, what then? What's next? You know, one thing Iboga doesn't do, it does not take our choice away.
No.
You know, it doesn't take the choice away. So we, in this time, after you take this medicine, you know, it stays in our cells, it stays attached to our neurons, and it stays in our fat stores, and it keeps replacing and giving us this boost that can last 3, 6, 9 months. Where in that time, we need to learn to make new habits. And that's part of the neuroplasticity of this medicine, you know, and the neurogenesis of this medicine.
Yeah, I think Iboga and Ibogaine are unique because they teach you about you, and they teach you about the why. They teach you about your mind, you know, they teach you about the stories that go on in the mind. And so one of the reasons for me that I feel like it works so well for addiction is because it teaches you about your addiction. It teaches you why you're like, why, like, what's the root cause? Why am I reaching for this other substance to bring you know, to cope or to function in life, right? So it shows us that. And it shows us in a way that's just for us. So the way it might show me, my mind, is going to be different than it's going to show someone else, because we all see and understand things in our own unique way. And Iboga gets the advantage of really, like when we eat it, it literally is up in our mind. It's there. And it's communicating without barriers with us. You know, whereas when we look at each other, and if we're talking to a therapist or a doctor, there's still nobody can get into our mind and really see, you know, what's going on in the subconscious, where that's where Iboga has the advantage. It sees our unconscious and it like opens that up for us so that we can see it. And like Patrick says, it never takes our choice away. So yeah, so, and this is hard sometimes for addicts when we tell them this, because we're never going to guarantee anything, because I can't tell you what you're going to do with the information you receive. But once you know something, and it's harder to then make that choice to abuse yourself, you know, and then it's hard. And then usually too, Iboga gives us the little gift of, if people do like step back in a little bit, they're like, you know, they want to do that one last little thing after they've done Iboga, it doesn't feel good. It doesn't give them the same feeling. It's totally different. And so they're like, you know, the odd time that we've had people say, yeah, you know, and it's usually for the softer addictions, you know, not so much the fentanyl and the heroin and that kind of thing, but the softer ones, maybe kratom or some of those ones like that. They'll take, you know, they'll do a little bit and they'll go, it just was wrong. Just nothing about it was good. It didn't feel good. It didn't make me feel good. It didn't do the same things it used to do. And then they don't touch it again. So it's, you know, it's just a really amazing, every time we work with it, we're amazed by it. We're amazed by how it communicates with people. We're amazed how it connects us to ourselves and teaches us. And I think one of the most important things is, we were kind of like looking into some different research before this call, make sure we were up to date. What I realized as I was looking at the research is all that is really beautiful, and it's so nice to know what Iboga does or Ibogaine does, and how it works in our body and the potentials of what it could do for us physically. But I think the most powerful thing that Iboga does is increases people's quality of life. And at the end of the day, that's what we're looking for. You know, that's what the research is for. That's why we want to cure disease, because when we're sick, it takes away our quality of life. And sometimes we can't take that disease away. You know, sometimes we just can't. We're not meant to live forever. And so then what? But if we can change our perspective of the place we're at and see it from a new place, from a place of, I don't know, human experience, then that changes the story. And that changes our quality of life. So, you know, I mean, and that is personal. There's no test that's gonna quantify that. So yeah, so that's kind of like this morning, as I was kind of like, you know, looking over stuff, I was like, yeah, but they miss it. They always miss quality of life. It needs to be at the bottom. Did it improve their quality of life? Yes.
Yeah, and I'd love to just share. I came with a history of addiction, but had been sober for many years. But I actually came to you guys with pretty severe life-altering PTSD. I couldn't sleep. I wasn't really able to do a lot. And I think one of the things that both in addiction, and whether it be behavioral or substance, or if it is PTSD, which is a mechanism of your body and mind are trying to protect you. Believe it or not, with addictions and compulsivity, you're also reaching for some kind of protection. You just don't realize like that's the wrong path. But I think there's an organizing principle that Iboga like very distinctly does for both those with PTSD, with just addiction, with many other challenges, it is a medicine of the mind, but it quite literally helps you organize around things. And PTSD is just this like disorganization, and addiction, disorganization, a diagnosis of a life-changing disease. Your life is all of a sudden not organized the way you thought it was before. And so, of course, it's going to affect your ability to be who you thought you were before. And it is a beautiful mirror for sure. It's incredible. Just my testimonial. But Jeannie, as you listen to what they're describing and your experiences and the research you've done, and both also personal experiences you've had with other substances that are more in the serotonergic world, what's your first thought about Iboga and Ibogaine?
Well, I have many, of course. I think I'll follow the breadcrumbs backwards, because I think, Michele, what you brought up about measuring well-being, having that be the primary outcome, is something that is a new talisman for me as I'm trying to build, trying to change or evolve the current healthcare system. And we all know well where we came from, where we didn't have any medicines that really have impacted humanity. Antibiotics, vaccines, better drinking water, and foods that we eat. No doubt. And all the medical therapeutics and developments, no doubt, have shown that we're increased life expectancy. But this model of tracking one specific outcome, be it a soft measurement of depression, anxiety. I mean, there are some things that are subjective, and how can we objectify them? Because whenever you add the subjective element, it gets a little difficult to compare, and so to look for a cause and effect relationship. So I was just recently writing a proposal. Instead of focusing on the reduction of depression, anxiety, PTSD, and the laundry list of ailments that plague our society, that really our primary outcome should be well-being. That if we aim for improved sense of well-being, we have to address mental health issues. We have to address physical health issues. And along that is, you know, the depression, anxiety, addiction, PTSD, you can't support the healing of that if you're physically sick. You're not eating right, you're overweight, you're not exercising, you're smoking, all these things. You're not sleeping. And so it's been while I feel like I'm paradigm shifting a lot, introducing psychedelic assisted therapy into mainstream, there's an equal opportunity to shift the narrative around what are the desirable outcomes. And for me, I want to just reinforce what you were saying, because I see it as the most important, is, do people feel better about life, about themselves, about their relationships, about their friendships and their community and the way they wake up in the morning? Do they want to wake up in the morning and embrace the day and find moments of joy and awe if they can? So that to me is now one of my North Stars. So thank you for pointing that out. As you were describing Iboga and Ibogaine, I have not experienced it, and it's something I would love to do, and I'd love to come down to wherever you are, and so I have respect for you. You described something that sounds very familiar to all the other medicines, the psychedelics, what I call the true psychedelics. So my definition of the true psychedelics are psilocybin, ibogaine, DMT, mescaline, and I'm forgetting one off the top of my head, LSD. Okay. Most of those, you look at the chemical structure of them and try to figure out where in the brain they're really acting. And while I say that that's sort of interesting to me, I do care about the etiology, how it works. To me, it's like, how can we possibly comprehend as a true alchemist, the human existence. And I'm going to suggest, against contrary to academic belief systems, that we can't really, that we're just sort of taking rough estimations of. Okay. With that said, the way you describe this medicine, that it gets to the why, that it helps take away, it helps change the narrative around a particular trauma instance, which I've heard your podcast before, and let me just follow this thought through. There's trauma in somebody's life, and there's a story that's built around that trauma. And like you were so aptly saying, it's almost an addiction to that experience. And I'm not passing judgment, it's just making an observation. And there's emotion around it, right? And there's a sort of an addiction to that emotion, even though it can be so harmful. So my experience with the different psychedelics is that they do help address the why, and that depending upon the circumstances for that person, that can be addressed. And however, the sustainability of that observation, to me, is so dependent on the ability to integrate it, to work with therapists, to be in community, of which you can talk about it and be supportive around it. So I think we all agree on that. I look at, how do we build that? How do we build that where there's quality control? And as you know, you can get a patient or two that can come into your clinic amongst the people you're serving and kind of take that energy away because of their own trauma. And one person can disrupt. And then how to have guidelines and ways to best handle those situations, doing it at scale, with safety in mind. So, and then I think one of the first breadcrumbs that you dropped was, I didn't know whether you were describing this medicine, because I haven't experienced it, more like a dissociative versus the tryptamine medicines, the 5-HT2A receptors, that, the DMT could mystical experience. And I thought maybe you could explain that a little bit more for me, who have yet to experience Iboga.
Well, I think that's in some way, it's kind of like a dissociative, in the sense as you are able to step outside of the attached emotion. So you're able to look at the trauma from a more detached point of view. So in that sense, it kind of pulls that. Yep.
Can I interrupt you? Because those very words are what I've experienced with the various psychedelics. So that doesn't help differentiate it for me.
So so that's what I mean. So it does that in that way, but you remain fully present. So in the sense that when often people are experiencing LSD, mushrooms, they kind of, and especially like 5-MeO, ones, that are like really
the rocket jet,
associated ego death. I would say, I mean, you're not really experiencing that with Iboga. What you're experiencing is you. And it's really hard to explain until you've done it. And this is the hard thing, because it's an experience. So I can give you kind of an example. It's more like having a conversation with a medicine that's very clear. So Iboga is very simple and to the point. And go ahead. So to me, you're staying in a therapeutic window. What you're describing to me, that often can be described with 5-MeO particular, it's like a rocket jet into like where some people can't speak, they can't articulate. Oftentimes I see people on all the other psychedelics, that can be true.
I don't think it's across the board, but I think it's true. But what you're discussing is that there's a good therapeutic window that allows the person to process. And that to me is key.
Yeah, so there's this really interesting, so we had a lady that was with us recently, and I love it because it's so, to me, it's so profound. So she'd been dealing with her mind. She had a lot of work, like we were really working with her mind and how her mind works. So very overactive mind, very in her head, like relentlessly so. And so, and just causing her so much grief in her life, just, and so at one point with Iboga, she was able to talk to God. So she asked God a question. She said, why is my mind like this, And God said, well, because it's like very young, it's like a 3-year-old. And she goes, well, what do I do about it? And he said, well, you just grow it up. And she goes, well, how do I do that? And he said, well, I can just do it for you now. And she goes, right now? And he goes, yeah. And so she goes, okay. And then we paused and waited. And she goes, God just grew up my mind. And so, even though she's having this incredibly mystical experience where she's talking to God, she's still very grounded and present and able to talk to us so that we can work with her in a guided sort of way.
Yeah.
And that is, I think it's that grounding. It's that even though I'm out having, in a way, a mystical experience, I'm really grounded and present within myself and understanding who I am and my ego and my stories and everything that's happening. So yeah, so it's really hard to explain until people, and this is why our community is for Iboga, because it's so different from the other medicines that once you've done Iboga, when you try to explain it to somebody who hasn't, like in a therapeutic way, it's really hard to convey what that is.
Different languages,
right?
Of course, it's called qualia, right? The indescribable. And I want to share that I've been blessed. I recently attended what is basically a designer drug that was incredible. I've never experienced some of the sensations, and I've been spending the last month trying to write about it, because how does this differ than my experiences with the other psychedelics? And so what I'm hearing from you is something that I struggle with myself, is how to accurately or even truly describe the indescribable. We don't have the lexicon. It's like that unspoken language in which we are remembering when we're in that space, and how to communicate that to others. And is it even a reasonable goal? Because I don't think it's possible, actually, at least right now. But then again, I want to support funding to explore this, right? So one of the real interests I have in Ibogaine is a paper that was published in 2023 in Nature, looking at traumatic brain injury. I work with Martine Palenka from Mission Within. I know Nolan Williams, who went out on a professional limb to look at traumatic brain injury patients, and they were able to show, they did MRIs of the brains before and after this treatment. And what was, I think, why the space is receiving so much attention right now, is that there was cortical regrowth. Cortical regrowth, which you're referring to as the neurogenesis of, which is really interesting, especially in light of all the traumatic brain injury, all the neurodegenerative diseases, which is an area of interest of mine. My second curiosity specific to Ibogaine is how it seems to, these early trials, kind of bypass the withdrawal symptoms And I'd like you to speak a little bit more to that. And of the, I believe you've done over thousands or 1,500 patients, that you have a sense of, of those patients that come in with substance use disorder, which are many, right? If you could divide them up into piles, if you would, just, grossly. And I'll give you an analogy. Mission Within, at the time I was on the campaign, we talked about they had 1,000 patients. Most of them come down with very traumatizing PTSD, suicidality, and substance use disorder, active polysubstance use disorder. They try to get off of the medicines before they get there, but we all know what that's like, right? So he was sharing with me, although this is not backed by like really following the data, but this is a wet, what we call in pathology, a wet read. He said 1/3 of the patients no longer used anything. They seemingly were cured, I think it's a word you could use if you follow it long term, of their addiction. He said 1/3 of his patients went from a harder addiction to a less addiction. So instead of heroin or alcohol where they're drinking themselves to death, started smoking pot. 1/3 of the patients, nothing changed. So I asked him, what was the difference between the 1, 2, and the 3 groups? And his thoughts were, is the will, the intention of the person who's coming to the facility, that they're truly on death's door. I know personally of 2 wonderful human beings that were guns to their head, ready to pull the trigger, and said, well, I might as well try this. And if it doesn't work, I'm pulling the trigger after done. Really, really, really rock bottom, done, suffering. And I'm really wanting to change at all costs. The other group was, yes, they are, but still struggling with some of those patterns and stories around addiction. And then the last 1/3, of which nothing changed, was that he thought that the patients came down because their loved ones wanted them to, or their kids, they were doing it for reasons outside of really, really wanting it for themselves. And there is a caution here when I say this, because this is a subjective opinion. And I always say, like, how do we judge somebody? Do you really, really want to get better? And it puts a whole narrative around that. Well, you failed. You must not have really, really wanted to get better. And then that has its own, spiral of self-deprecation. And, so I just was curious what your experiences are on this.
Well, thinking back for all the years we've been working with this medicine and with different people coming through, it's very similar to the 1/3, 1/3, 1/3. It really is, And we have, the ones that leave and it's, some people just make that conscious choice when they leave. It's like, I'm never doing this again. This is what I feel like now. This is what I saw during my psychedelic journey, and I can't unsee it. And I'm not doing that ever again. And they break that cycle. And there's that window of 3, 6, 9 months. Some call it a pink bubble. We call it the Iboga afterglow, where you've got all this extra serotonin boost and dopamine boost, and you're feeling great, and you're able to do stuff, and you're neuroplastic, and you can remember things and create new ideas. And so they take advantage of that, and it works really well. And then you have some who they're just committed, and it's that's what how you're saying is, you can't pass judgment, because everyone comes in where they come in. You get in where you fit in, and the medicine meets you where you fit. I always tell people, you don't want to come in like Kramer coming into the door in Seinfeld, because you come in all frazzled. The medicine meets you there and starts working with you there. When you come in with a lot of reverence and respect and intelligently set intentions, it meets you there and starts working. But it doesn't take your choice away. So some, they a lot of times they'll weigh it out. Well, at least I'm not doing heroin anymore, so I'm still smoking. I'll worry about that later. Or I'm I'm vaping or I'm using Hape or whatever. And, I know I should probably cut down on it and caffeine, but one thing at a time. And what's truly important for them at that point is their quality of life is tenfold. That's what we're shooting for, is this huge increase of some sort of quality of life where they can live to their fullest potential. What's their fullest potential? It's theirs. It's not mine. It's not yours. It's theirs. So when I see that, I'm like, okay, one foot in front of another, with this tradition, with the Bwiti, they have a saying, it's called Malembe Malembe, which means slow, slow, little by little, we have it, 1 foot in front of each other, or, one moment at a time. And it's really important. Then you have the others who end up relapsing, and inherently they get stuck back in that part where they were before. And yeah, it's true that, some of those people who fall into that category are people who've come because of spouses or family members, and they have ultimatums, or they're, well, if I don't do this, my wife's going to leave me, and all these things. And sure, I mean, those are good reasons to stop. But breathing is a good reason to stop too, And for whatever reason, they slip back into it, And I see where a lot of times people are failed. I mean, first of all, you have to be accountable for your own action, for your own sobriety, for your own well-being in life. But we need to, as providers, we need to uphold our responsibility to follow through. It's not a one and done. When we have someone come through our doors, it's not one and done. It's we're now connected, and we have a responsibility to help you with integration. And what does that look like? Well, invariably, it's different for everybody. Now, we can't walk around holding your hand the whole time, but we can be there. We can be an open door. We can be that window in that house on the street that says, this is a safe place for kids. Ring our doorbell at any time. We can be that. We can make it available for them, And like I say, it doesn't take our choices away. So it's like, there's a thing we call, it's that part of feeling too good after a treatment, And that can be a real downfall, because you can come out of it feeling like you just come out of Tony Robbins' weekend or something, and you feel like, I'm bulletproof, I can do this, and Jeff and Jack,
change the world.
Jeff and Jack, I haven't seen them for a while. I know they're smoking meth down the corner, but you really want to see me. Oh my God, I love those guys so much. I'm good, I'm solid. And you're gonna start hanging out, and before you know, we all know how that works. We know how that works. And so I'm going to mention about this neuroplasticity thing, because just as much as you have the ability to learn new things following your experience with this medicine, and you can have just a beautiful experience moving forward and learn new things, you can also remember your bad habits and relearn them, and you can relearn them even more.
Yeah.
So you can, and I did that. I was a smoker for 50 years. And I chose to, well, I'm just not quite ready yet, so I'll do it. And I tell you, I went from smoking a pack to vaping 2 packs worth a day and smoking a pack.
Wow.
Like, I mean, I really relearned that in the end of the year and a half afterwards, and I really relearned. That's neuroplasticity for you at its finest and its worst. It's our choice what we want to do with it. So it's the onus on us. It really comes back to us. Yeah.
And I think too, like, we know, of course, we know a lot of the people you're talking about. We've been in this community for so long. We actually, one of the ladies that we work with that is a dear friend of ours and has gone to Africa with us. She is one of the therapists that works with Mission Within, and she's working with us as well. So for us, the biggest downfall to those particular programs is they're too fast. They're a weekend.
Yeah, right.
And that being said, they do get, Mission Within is actually quite good. They do get a lot of pre and post, preparation, integration. I'm
Right.
not
Right.
dissing them at any level. It's
Right.
it's when we take, see, the problem with, for me, the biggest problem I see with our current healthcare system, or the way we view healing, is we think it's a
Yeah,
treatment.
I get it. Believe me,
Yeah.
I don't want to change it. And it's financial. It's financial, right? So, you know,
It is.
paying for a therapist's time, because
Yeah.
it is time, it's a service rendered, and that's the problem in this space. That's
Yeah.
one of the problems in this space. I just wanted to add this, my course. I agree with you wholeheartedly that, you know, one's reality is based on one's perspective. So when you're talking about neuroplasticity and how these medicines can help some and not others, I think about, what is the difference? Is there some biochemistry within them, or their neuroanatomy, their receptor profile? For instance, patients used to die with complications of diabetes till we understood that there's insulin resistance and we can give insulin and prolong life. I'd love to have the finances to explore, the funding to explore, are there biological biomarkers that within a person that could help discriminate between, well, they maybe benefit from ibogaine versus, say, psilocybin based upon their genetic predisposition or receptor profile. And so that's one of my science brainiac thing. The other is I'm absolutely biased towards the integration portion of this therapy. Neurons that fire together, stay together, you keep the narrative, and you can have a honeymoon effect of the person thinking I'm fine, and then they go back into the environment, like in the example you gave with the meth addict friends, and then they're back into it. Your own example of smoking, change, and then you go back into it. There's I think a combination of understanding maybe some of the neurochemistry with support through it. And not everybody needs it either. So, also you have to say, not everybody needs to be in, community health. It sure feels, and now I'm going to go back to just a feeling I have personally about this, as a human being with needs, strong needs, and I say this needs in a proactive way, not out of weakness, but out of strength, to connect and commune with others. Yeah. To me, it's just as important as breathing. Yeah. Right? So, to create community of which one can be a part of, and be with people that have experienced not only some similarities that brought them to, say, Ibogaine or the other psychedelics, and that can speak to this unspeakable, right? The qualia. You don't know what it's like until you experience it. And to try to share this with people in your lives and your community that haven't experienced it, I found it's like it's a foreign language. It's a and you can kind of look at each other and go, okay, but I describe it as I'm a mother of 5. Before you become a parent, you think you understand what it's like. Those people know, they know, right? There's definitely a before and an after. And it would be like talking about parenthood with people who have never had kids. So how to support the infrastructure of community, which is important. And perhaps we can even talk socially how religion used to play more of a role in communities. Community that seems to have dissolved for various reasons. I'm not going to pass judgment, but replace it with something helpful and meaningful that is supportive of one another. So,
yeah, in your article, I read the article you just wrote, and you wrote something I thought was just beautiful. And your quote
which one?
I've written lots.
Oh my goodness.
Loneliness.
On loneliness,
Oh yeah.
And it says, loneliness then is not just the absence of others, it's the presence of disconnection. And when I read that, Michelle came down this morning, I went, it's talking about Iboga. Like, I mean, it's talking about what we do and what we see, because, you know, one of the big things with this medicine is reconnecting us to our soul, to our higher self. I mean, we're walking around as these unconscious travelers in this life, you know, in this experience, lonely, searching for things. That's why we reach for all these different things that some harm us and some enable us and some are good for us, you know, and it's that loneliness, you know, and people will say, I'm a self-made man. I don't need nobody. I'm an island unto myself. That's not about how we were made. We're tribal people. We're a community.
Yeah.
You know,
Yeah, I
and
agree.
getting back to that, that's
Yeah.
where I see us really happening with these movements. And I'm
Yeah.
all for it. Any way this can be moved forward can be a positive, because it's getting back to the rudimentary of who we really are, that remembering
Yeah.
of ourselves, of our community. And I mean, I love the idea of connection
Mhm.
and reconnection.
Mhm.
It's so important. But so I just loved how you said that, because it's like, yeah, really elegantly said. Thank you.
Thank you. I was curious, since you're serving medicine in Canada, where it's more acceptable, can you share the societal perception of these drugs? I highlight this because of what I call the hangover effect of Nixon's Schedule 1 and then Reagan's Dare Say No campaign that is still like a wet blanket. And I'm actually asking even beyond that, because these medicines and mind altering substances have been around in society for a long time, and sometimes there's pushback and sometimes there's acceptance. And I was just curious what your thoughts are about that.
I would say for us personally, we've always had positive, very few people have a negative reaction. I think because people are wanting, or I think a lot of people are happy to see people do better in their life, to see people find more joy. So even like when we have when we have couples, like and only one comes to the medicine, where that partner might not understand why they want to do it, or they're like, I don't know, it's not for me, but you do you, because they see the shift, and they're happy that their partner is happier, they're happy that, for the most part. I mean, sometimes, it doesn't work that way, but, and then like, even for us, when we talk to medical professionals, which, we probably have more so than most people, just simply working in a hospital and being around people like that, most of them are like, great, if it helps people, I'm all for it. Like, but then the paradox of that is, if they have to put their license on the line, then they kind of back off. They're like,
you can't do that. You can't do
great.
that. It's their livelihood.
Yeah, it's, but I can't, I'm not gonna get involved.
No,
So it's in this kind of like, because for Canada, it's kind of gray. It's not really illegal if you have it. It's, you're not going to jail, but you should be, it is supposed to be prescribed. And it's in that category of allowing to be prescribed for trials, but they haven't approved any trials. So Health Canada is kind of like, yeah, we know it's there, but we're not going to really play with it too much. So it would be nice to really get Health Canada to be like, okay, we'll do a trial. But so far we haven't done that yet, but I feel like it's probably coming.
Yeah. Well, maybe that's something we can collaborate on.
Especially because Native American groups becoming interested in it. And for the United States, it seems to be vets that are really the pushers, but for Canada, a lot of times it's the Native American communities. And if they're saying, hey, look, and I think it's because they're
suffering so much.
Yeah, well, suffering so much. Also, their connection to land, like there's sort of like, for some reason that's not a reach when we talk about Native American communities using plant medicines. They're like, oh yeah, of course they can do that.
Well, they're familiar with it. They've been using it, you know,
Yeah.
in their culture. So it's like that, not something new. I had a couple
Yeah.
thoughts. You know, in Canada, their healthcare system politically, they're much more interested because they've set a certain budget that's going to be allocated, and so it's more about outcomes. Our system is not that, and it was focused on, well, it can be malaligned. Let's just put it this way: not about the improvement of the society at large, even though there are arguments that we have extended life expectancy and things like that. And I'm wondering how to change that narrative, because really that's what's important. And one of the, well, I'll go out on a limb and say one of the slivers of hope in the utter destruction of our institutions and employees that support our citizens in the current administration is that perhaps there's an opportunity to change the narrative around healthcare. And I mean, that's my idealistic and optimism speaking. So, but I think having more information, more patient accounts of it being improved, of life-changing accounts, and also being realistic. Let's talk about some of the negative outcomes that you've had, patients who come in that do not have a good experience and who relapse worse or brings up some other trauma that is requiring of really a lot of hand-holding, but you know, they can, you know, how do you deal with that?
Well, it's really on a person-to-person basis. I mean, we've had people, a very small amount, but it's there. And you know, when you're in the medicine, you see things, and it shows us ourselves in our raw form, you know, and this medicine has that whole persona of being the Mount Everest of all medicines. And it's, you know, some will say, oh, I can't do that, it's so dark, it's too dark, I can't do it, oh, it's too much, it's really hard, you know. And because it shows us our stuff, and it doesn't show us different stuff, it's just our stuff. It shows us. And you know, sometimes people see this and they just don't want to see it, and they don't want to accept it.
Scares them.
They don't want to take responsibility for it. See, it comes up every time, and
that's key.
Yeah, and it's not about gaslighting people. It's just this is the truth medicine, and so it's just real truth is that it comes up for you to see, not to shame you, not to make you fearful, so you can see it, so you can move through it with it, because of it. You know, you don't forget it. It's not about forgetting the past. It's about stopping that emotional charge that writes this other narrative that we become slaves to. But it's owning it, and if they don't want to see it, if they don't want to look at it, then they can become very distraught and they can become angry, you know, and they're like, oh, this is not working. I'm just going to leave. Well, once the medicine is calmed down and you're in a place where it's fine, then we can look at that, you know. And it's just really meeting them where they're at. We have to meet people where they're at every time. And sometimes they're here and sometimes they're here. And it's being able to meet them where they're at, because, you know, it's not about us. We're here just as tools to be in this space to help people where they're at. You know, when we can all do that, then we shouldn't be in this space.
And I think too, there's an interesting thing here that we're talking about, that we're talking about consciousness, and we're talking about experience, and we're talking about spirituality. And even though that these things don't normally come up in a lot of healthcare conversations, it is key. Like, it is body, mind, soul. So, and if you don't believe in a soul or God, then it's creation or whatever reality, whatever paradigm you sit in. And Iboga actually never tells anybody what to believe. So it doesn't matter what religion you come from. It doesn't matter if you're an atheist. It's going to work with you all the same. So there's this so for the Bwiti, for the people that have been working with this for thousands of years, they'll say for some people their soul isn't ready and you can't force it. So we are talking about shifting paradigms. We are talking about creating new understandings of what it means to be human. And it's why we can't explain it to somebody. How long have we been trying to explain consciousness? We haven't even begun to figure out what consciousness means. And now we're creating AI and trying to govern AI consciousness and what that might look like, you know, like so consciousness is really difficult. And it's why we have to be like so careful. And this is what scares me about the interest in these medicines sometimes, like the Joe Rogan sensational interest. Because like Patrick says, you can't just go around unzipping people and then not zipping them back up.
I agree.
Right?
Agree.
Dangerous.
Yeah. It's not the enthusiasm as a cure-all. We're living in a society that wants a quick fix.
Yeah.
Take a pill, you're going to be all better. Oh, hurry, and you're going to be happy.
Yeah.
There's so many areas that I'd like to go down a rabbit hole with you. So, and I don't have a pen and paper. We're going to keep track. Yeah. One is one of my recent focuses is on writing about consciousness and the evolution of life on the planet and where it goes, and how does memory, imagination, and creativity play a role in defining what consciousness is, and how my own experiences with the various psychedelics have opened up portals for me to peer through with reckless abandonment and wonder and awe, and see if I can glean any insights from my own personal experience to share with people on a page. So I do appreciate what you're saying, that these medicines give one access to an altered state of consciousness that, depending upon the dose and the type of medicine, allows one to stay what we define as, say, a therapeutic window of awareness, of being aware of what's unfolding. It'll be interesting for me to explore how Ibogaine in particular is different, if it is different for me personally. So I look forward to that, to put words to it. But I'd like to kind of steer the conversation to your thoughts about building out the therapeutic model, your role as guides. You're more than just a therapist. You are alchemists. You with all your experience, I'm sensing this from you. You can sense that undefined sense of a combination of listening to a person's history, reading their body language, and then when you're with them, my guess is that you have an intuition, something beyond an intuition, of which you can help guide. And I want to say, is that true? Ask the question, is that true? And then, right?
Well, yeah.
And then, knowing that that's true, how would you train other therapists in this practice? Is it truly like we had in medicine years ago, where we were called in-house officers because we actually lived in the hospital? That was when I was training, because that was the way you learned. You learn by experience and seeing multiple cases. I understand you've helped like 1,500 people or something that along those lines. That's an enormous amount of hands-on experience of which you've honed your craft of guiding and facilitating. And so I want to hear more about your thoughts on that. And then also in the other psychedelics that I've experienced, touch is very important in healing. And when I mean touch, it's a non-sexual touch, but it is a compassionate, loving, supportive, empathic touch. And it feels like Western society has separated itself from touch. And you can see in other countries where boys are holding each other's hands and hugging each other as they walk through. There's a communal touch that,
Mhm.
you know, there's a fine line
Mhm.
between this touch and then how it can bleed over into abuse. And I'm very keenly sensitive to how to hold that boundary, because I think there's something invaluable about effective human touch, but it just can easily cross a line. And so because that portal into crossing a line is sexual abuse or sexuality, so then on a larger system program, you'll say no touch is allowed. And I think that that's I'm just curious what your thoughts are about both of those questions and observations.
Can I jump in as an experiencer of being with Patrick and Michele? One thing that I think can be learned, but is honed in a way that you can't just, do a weekend, and figure it out. I know, because I know Patrick and Michele, I know they have bedside manner. They quite literally sat beside probably thousands of people, But the first things first, if people are considering this experience, understanding the first contact, even if it's from distance, to wanting to explore this experience, recognizing that there are medical risks and that there are things that you have to consider. You must do a 12-lead EKG just to start the conversation. You must do a blood panel. And Patrick and Michele are very skilled at reading those things. We also, when I came to my first ceremony, before I walked into the space of ceremony, we also did a secondary EKG. It's a mobile one that he has. And just to double check that today you're okay for this experience, above and beyond being on site, having conversations about what this is going to be like. And then when you're in the space, there's very clear, first off, their medical training is invaluable because, I just to speak to your touch, there was a moment where I remember begging for a banana that someone wouldn't give me. So banana will cut the really extreme aspect of Iboga. Who knows why bananas do that, but apparently they do. I don't know, I never got one. But I was in a particularly challenged space. And Patrick came over and he just gently kind of went, just a little bit of that. It was comforting to me, but he was actually taking my vitals. He was checking her heart's not racing. He's not grabbing right here. He's just gently holding my wrist to see, and then touching for clamminess, but also comforting me. Those are things that are incredibly important, because in that moment I went, oh, I'm not going to die. Can I still have a banana? Okay, no, but those kinds of things, they have dual purpose, right? Because he's checking my vitals, but he's also got a skill there. Above and beyond that, there is an intuitive knowing, not only of, he read my blood panel, he knows my EKG, he also dosed me personally, transcribed those doses, he knows exactly what he's giving me, but he's also checking for the awareness in whether or not I'm able to make eye contact, whether I'm able to even open my eyes. Can I sit up? Can I stand? Something that some people have more than others. I had really an extreme case of was vibration in my body over and over. Partially my dance, I think, was coming out, to be completely honest. The dancer was coming out. But there is a block, as I understand it, and please correct me if I'm wrong, but the reason Parkinson's causes shaking is because you have an inaccessibility to your dopamine. For the time being, when you're in the medicine, it's almost like the reuptake is blocked during the experience of Iboga and Ibogaine. So you do have tremors that are very similar. You need to be picked up and held to go to the bathroom. You need to have a built trust with that person. And that's something, it took many years of training with other people, building trust with people who are in life-threatening situations because they're in ER and surgical ER rooms and things like that. But above and beyond that, having just the experience with the medicine to know what's going to happen, and then also to know what to look for in a person experiencing it. Those are things that are just experience. And that means it's not something that you can do on a remote program, like coaching thing that you like watch some videos and then you're ready to serve medicine. No. Sorry, I will always...
Could you, of course, that was, could you guys speak to the cardiac effects of prolonged QT interval and the cardiac arrhythmias that are associated with this medicine and death under unsupervised places? And then, when I hear Kim speak about the physicality of this and the potential complications, it gives me pause. How to scale this medicine. And then I can make an analogy in my mind when we first brought on amiodarone, which is a type of a cardiac medicine that they would be in an intensive care unit, you would monitor them. And now it's just something you give practically over the counter. So would you address some of your experiences and then medically, and then last thing I just have to add, because I can't help myself. When we're trained in the medical community, I was taught early on about boundaries, what is acceptable, what is not acceptable. And, if you break that, you could lose your license, right? So there is a threat. And so I'm raised in that, and I believe you too, you both are as well as a nurse. So a lot of the therapists and facilitators are not. So I just wanted to bring up that differentiation. Okay.
Yeah. Those are a lot of points there.
Yeah.
Let's talk about the cardiac component. So I'm glad you brought up amiodarone because, and there's digoxin, there's all these other blood pressure medications and different things. And when people take these, they're not done willy-nilly. They're not just done whatever. They're done with thought, with care, with intentionality by their care facilitator, their doctor, the practitioner. That's the way it should be anyways, right? For the most cases, that's how it is. And each and every medicine comes with desired and undesired side effects. Okay? Well, medicines are medicines. And we can't forget that these plant medicines are medicines. And they have real effects. The one thing I know for a fact is that, Iboga is not dangerous. It never will. Its intention when you take it is never to harm us. The part that's dangerous is the human part of it. It's the humanality taking it or directing the process, because Iboga comes in and it suppresses the hERG channel, sodium channels, and the calcium channels, which can slow your heart down. The potassium channels can actually lengthen your QT interval, which is that time of refilling in your heart rate and such like that. And on its own, it's fine. But if we're not doing proper pre-screening and proper evaluating of these people coming in, then they're coming in with conditions that are having long QT syndromes or Brugada syndromes or different things like that are already putting them at jeopardy for having this potential, or they're taking medications, or they're taking supplements that can potentialize serotonin levels or potentialize the elongation of QTs. So when you put it together, if you're not watching it, then you can perhaps have these sections during a treatment where it can be life-changing, life-altering, life-ending. It's about really doing due diligence, from the participant as best as they can, but it's on the onus of the person who's giving this medicine, who's doing that. We used to have our doctors would come in on their rounds in ICU and they'd write the orders. People say, well, it's on them. No, they're a component of it, but I'm giving this stuff. So I better know. I better use my judgment properly because it's on me too. And so it really is on the place you're going to have these medicines. What are their qualifications? What do they know? Like, do they really know? Do they know both worlds? I love the fact that we know a lot about both these worlds to make it a safe place to come and do medicine, because there's a way to navigate through this in a very safe way, in a container that not only makes the participant at ease so they can just, like Kim's saying, you just kind of go relax and just go in and surrender and just explore what they need to explore, knowing that they're being held, and the providers are watching.
Safe.
Yeah, they're watching
Safe.
how you're breathing, if there's any changes, or you're looking out from outside the box too, in before things happen. You don't wait till like, oh, they're not breathing. No. Oh, I see that they're a little more restless than they were 5 minutes ago. Why is this? We're constantly thinking, we're constantly assessing. That's part of it, neurologically, physically, spiritually, even. So these are really important things. And there's a real important part of it with that QT, which can lead you into these arrhythmias that causes torsades. And it's a life-altering, life-ending thing if you don't end up getting to the hospital like right away.
Having someone there that can deal with it
You know,
immediately.
And if people say, well, I can get magnesium at this, give me some IV magnesium at the clinic, I'm good. It's like, that is not the same as having 2 grams of IV push now, then hooking up to a small mini bag and constant monitoring. And if you're at that point already, well, maybe there's magnesium that's out, there's potassium that's out, there's sodium, there's all these things that need to be done.
Yeah.
And like even on that point of it, we see people who end up, so not having QT problems for that, but they go into dehydration mode, from repeating this vomiting, right? Purging, and and it's hyperemesis, and aren't really watching their intake and output, what's going in and how much is coming out, and which end is it coming out.
Serious.
So it is very serious. It's life-threatening.
Yeah.
It's really learning how to do that and being aware of that and knowing that, this person that we can't get their vomiting under control. It's okay to go to the emergency department where they can have this other access to it. Because it's not about us. It's always about the participant. And it's knowing to do that in a safe way. It's about a really safe space for this.
Yeah, and I think that's the control of it is the harm, because if a provider is afraid to take their client to higher levels of care because they don't want to get into trouble, that's,
that's a problem.
Yeah,
So, they say, wait, are you there? In medicine, I was taught early on to know what you don't know. It's almost more important to know what you don't know than to know what you know, because if you act like you know what you're doing and you give somebody something, you do something that could really harm them. Could you share with me some of the medical contraindications that you have? And then, somebody who has a history of atrial fibrillation, do you notice, does it increase their chances of an arrhythmia, or does it come back? Or tell me some of the medical things. And then you mentioned hyperemesis. I mean, what percentage of the people that you have served, if you could just sort of ballpark it, have hyperemesis? And then lastly, because I have a multi-question, do you drop IVs in them so that you could push some fluids or some anti-emetic medication to add magnesium or whatever? I'm just curious what your thoughts are on that.
You want to start on this one?
Well, I can speak to some of it. Patrick's probably better to speak to the cardiac stuff, as far as contraindication is concerned. So for hyperemesis, it's really rare. It's pretty rare. So we're really mindful for us anyway. We can only speak to how we do it. And we even in the last year had a couple of clients that came to us and were really mad we wouldn't give them any more medicine. And the reason we wouldn't give them any more medicine is because they were getting up. They were clearly doing a massive physical detox. So they were getting up, going to the bathroom every 20 minutes, having loose bowel movements, vomiting. You know, we're like, your body's saying no more. You might want to go out and have some psychedelic experience, but right now the medicine's working with your body and it's your body's at its limit and we need to respect that. And of course, they didn't like it, you know, because they don't understand how bad can go until, you know, you're in the position, right? So sometimes we say no to people because in the medicine, because we can see that their body's had enough. And that can be difficult for a provider, especially when the client's challenging them. You have to really be able to stand firm when you know.
Yeah.
So hyperemesis in of itself, I personally know of one outside of us where somebody did, as far as we can tell, that was the cause of death. It was recent in Costa Rica from the bit of information we have. And it could have easily been negated if they just gone to the hospital. So, you know, it's, you know, hyperemesis is usually like something, as long as we're replacing those fluids and it's like
Right.
And as far as, well, contraindications, it's like, there's quite a few, but manageable. So a lot of the mental health medicines, we don't like to blend with Iboga. And Ibogaine and Iboga, Ibogaine, you can be a little more lenient, like
On certain things,
mildly
yeah.
more lenient with some things. It can, because it's just the one alkaloid, where Iboga is a bit more complex. And then, so a lot of the mental health medicines, you know, because they affect dopamine, because they affect serotonin, you know, especially serotonin, if we're on medicines that really boost serotonin, even natural herbal medicines and concentration, right? And then we give Iboga, which is going to flood you with serotonin. And then we're going to end up with serotonin syndrome. So we never want to go there.
It's pretty rare though, right? It's like
Probably,
really rare.
Yeah, probably, but it's not worth
It's scary, but scary.
Yeah,
Yeah.
and there's different levels of serotonin syndrome. Where you feel like garbage, and you know, as long as you stop giving what's causing it, it can dissipate if you catch it early enough.
Yeah.
You know, I really believe that's probably happened a lot at different things because people aren't aware of it.
Or
You know? Yeah. You know, like most people don't understand what sideways looks like until they see it.
Right.
So
Is there anything you can give a person to help slow down the effects or reverse the effect, like Narcan, for instance, or is there any antidote? Yeah.
Well, in Africa, they have certain things, but we don't grow them here. But you know what Kim was saying, there's a banana. So why banana?
So potassium, I mean, that would be the...
Well, I've looked at it and I've asked our elders, is it potassium? What is it? And they just say, when you're given bitter, take sweet to stop the bitter. And like, okay, all I know is that it works. We've given people bananas before where it just kind of slows the effect. It doesn't stop it. It just stops, you know, potentiating of it. But it doesn't take it away. They actually have stuff in Africa that we don't have access to here in our jungles. So that's fine. But you know,
it would be interesting to have more study on that though, but you need
right. Sugar. I mean, I could see you can be hypoglycemic too, and that could be probably. What about other mental health issues? I mean, somebody with a history of psychosis who's now manageable, is that a contraindication? Manic depression, who's, you know, well managed on medical therapeutics?
So according to the Gita handbook that was around, the answer is no. And
so meaning that's not a contraindication. You will treat those people, or you will not.
No go. It's a no go. It's a contraindication. But
find Gita for everybody, so because that's an old.
Was the Global Ibogaine Therapy Alliance, and it was a handbook you could go to with inclusions and exclusions and different things. And for a person who was just starting up a clinic, whatever, it's a great guidebook. You know, I recommend it. At least then, if it says no, then you just know.
Right.
But as we know,
Mhm.
you know, in the
Right.
health profession, when you've been around a long time, not every schizophrenia, not every bipolar incident
Right.
is the same.
Right.
You have to,
Right.
and so you can treat people, and we have, but it really is on
Mm.
an individual basis. Like, are they manageable
Mhm.
off their meds, and for how long, and what does that
Mhm.
look like?
Mhm.
You know, and
Mhm.
then are they lying about it?
Mhm.
You know, and that happens.
Mhm. Yeah.
You know, and we've
Mhm.
seen that
Mhm.
where people
Mhm.
say they've been off and everything else, and then your intuition, working with the medicine, you pick up different things and their mannerisms as they're getting ready to take
Mhm.
it, to see there's things that are off. You can just tell. And so it's like, you know, we had
Mhm.
one person and they were off everything for quite a long time with their parents saying, oh, yes, 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 everything's good. And I said, well, just give them like a quarter of what everyone's getting to try it.
Yeah.
We always start with a
Yeah.
small dose. It's like a handshake to see if there's going to
Yeah.
be any reaction to it,
Yeah.
or how they're going to
Yeah.
respond. And I said, just give them a little bit. And within about a half
Mhm.
an hour or so, they're up arguing by themselves. Everything okay? So, oh yeah, it's good. Well, come on back. We're talking, and then again it happened. I said, well, so I'm just going to let you go back to your room tonight, and we're going to discuss getting you back
Mhm.
on your medications tomorrow. Oh,
Mhm.
okay. And
Mhm.
so we
Mhm.
found out, and I took him to the hospital. I said, we're going to get him started back on his medications. And the doc said, I want to talk to him. So I left the room and listened. And he said, well, you've been off your medications for how long? Well, for 3 weeks. You had to make sure I could be off this medicine. And he said, well, how did you manage? He goes, well, I managed. How did you manage? The doctor said. He goes, well, I took like 2 milligrams of Ativan about, 3, 4, 5, 6 times a day. And that kind of helped everything. And I'm like, I went,
Yeah.
gotcha.
Yeah.
That's
Yeah.
why.
Yeah.
And so,
Yeah.
but you
Yeah.
can't, it's on a very individual basis. So it's knowing how to navigate safely through. Because
Yeah.
the unfortunate thing is
Yeah.
not everybody, see, everybody could benefit from this, but not everyone can.
Right.
And that's okay. We all have a journey. We all have things we have to go through, and that's okay, and she's frozen, but
I think there's just some.
Oopsies.
but nonetheless, we all have to invariably go through a journey on our own, and we have to be able to recognize where people are with this, and so we can help them come safely to this medicine.
We just froze there for a second.
Okay. Refrozen now?
Yeah, the signal's not so good. I don't know what happened.
You're back. You're back.
Okay, yeah, I left, but here I am.
Everybody's
We were
here.
here.
So I just want to play devil's advocate really quick
Right.
as an extension of this.
Yeah.
So, can I just microdose this then? I mean, like, that's cool, right? On my own, I could just get it on Instagram.
So microdosing is interesting and it's coming up a lot. Traditionally, of course, they would say until you're initiated, you shouldn't be taking the medicine unless you're with somebody who can serve you the medicine. And I would love to see more work with low doses. When we do, when we use the medicine for Parkinson's, it's in low doses.
Mhm.
And so, it doesn't have to be the huge, massive, like hit you over the head, kind of experience. Like there's lots of benefits to this medicine. It's doing a lot of things for us, even at really, really low doses. But I feel like there's no research, I'm sure, on that. If we wanted to look at it in that angle. And so because it has such a big contraindication like profile, so we say to people, well, number one, we say to people, medicine, like this isn't coffee, right? We have to have a lot of intentionality. Iboga is one of the biggest ones, one of the biggest psychedelics. We're not messing and playing around with it. It doesn't want us to take it and then just go about our daily business. And I've seen it with people who've microdosed. We had a lady that was microdosing it and stopped because she was getting numbness and tingling in her hands and feet. So whether it was just lighting her nervous system up too much, it was just too much stimulation, or whether it was like a neural pathway thing, or whether, who knows, right? We just don't know, right? So, but that being said, they microdose it in Gabon, like they use it a lot, so they'll use it during anytime they're going out into the jungle, because they use it to talk to the plants, they use it to understand the jungle, right? So, so I think microdosing is great. I still think it should be done with a provider that really understands the medicine. It's gonna bring stuff up for you. You need to be doing it with somebody who's gonna help you work through what it brings up. So we have a gentleman right now that we're working with that is young, he's like 45. He has the beginnings of Parkinson's. And so we're working with him for that. And so he started on very low dose, like 10 milligrams. Like we literally had to get a new scale because it's such a low dose, our old scale wasn't measuring it. So and so we're gonna monitor how that feels, and then he's gonna come and do a bigger dose with us. And then we're gonna continue to monitor him. So I think, you shouldn't just do it on your own. Why are you doing it on your own? You haven't been you're reaching for help. You want help from a medicine. So do it with somebody who understands the medicine to help guide you when it brings things up for you, or doesn't bring things up for you, or maybe needs titration or whatever, right? Like there's so many things to that. And you have to be prepared to give up all the things that comes with that. No cough syrup, no allergy medications. Well, there's one you can use, like all the things you might just casually reach for in your life without thinking. Now you don't want to be layering that on top. The likelihood of anything happening is very, very small, but I can't rule it out. So I'm going to say, just don't do it. Right? So.
Can you speak to the source and the consistency of the source? And is it endangered at all? So I'm thinking about peyote and the 5-MeO from the Sonora toad, the exploitation to get these medicines. And then lastly, like psilocybin, we know that each mushroom can have a different amount of psilocybin in it. So the consistency of a gram of this mushroom is different than a gram. Can you speak to this with Iboga, please?
Yeah. So Iboga traditionally is grown in Gabon, in Central West Africa, and into the Congo Basin. And there's even parts up in Senegal in the north where it's grown as well. And the Iboga we're talking about is Iboga tabernanthe, okay? And there's Volcanga, and there's other various types that have different amounts of Ibogaine in it, and of course the other alkaloids are all varying differences. So if we're talking about the tabernanthe Iboga that's in Gabon, there's plantations around, there's wild ones, and villages have their own little bits. There's a real risk of being trampled by elephants. Like 70% of the
work hazard. Trampled by elephants.
Yeah, 70% of the forest elephants live in Africa are in Gabon.
Yeah, that's
and those things
really? Is that right?
No,
I didn't know. Yeah. No.
And they love Iboga.
They
So they
love.
will
Yeah.
love Iboga.
They will. They love it. They'll pull on the root systems, and I'm sure that helps ground the roots in more. But they take it, and and in certain doses, it's an aphrodisiac, and then of course it repopulates the earth and everything else. So it's a real amazing way of being. Sure.
Life cycle.
So that part is just the elephants. Then there's the poachers. Then there's the black market. And there's a lot of people who are going in there taking it without
drug,
proper ways and without permissions, and there's no reciprocity, and they're selling it in the black market. And so, I guess on its own, if someone was just selling real Iboga on the black market, I guess you're getting real Iboga. But the problem is lot of times they cut it with stuff. And people are like, why would they do that? Well, the same reason the drug dealer will
Oh, we
put
know, right.
their
Yeah.
opioids and get more, people addicted and everything else. And there's no real rhyme or reason, but it's what happens. And it can really have catastrophic effects. So, there's a lot of things like there's different groups, ICERs, there's Blessings of the Forest, there's the Nicoya Protocol. All these things are being put into place to help protect, this plant medicine that's there. And it's a national treasure for one, so exporting is really tricky. And I know being worked on right now to have it more available for that purpose. But it's really important of where you get it from, and having a relationship with that.
And it's important to state that it doesn't grow well outside of Gabon. And that's, I know people have tried to grow it in South America and the thing is too, it takes 7 to 10 years for the plant to mature. So it's not like you can plant it next year, it's good.
But it's not so slow growing like a peyote plant that's 100 years. And
it grows, and the alkaloids vary in it. Of course, Ibogaine is quantifiable. That's why it's being studied. Where Iboga, the amount of Ibogaine it varies slightly. The older the plant, the more potent the medicine. So
is there any kind of quality control on that? Is there any kind of quality control that or you have a particular supplier that in general harvests it well and checks for general consistency at the very least?
Get it from
from our village. Get it from our village, and we've used it in their village, and we've used it from their village. And so
they're the ones telling us it's good.
So they'll say this particular batch is stronger than the last batch. Is it that kind of just
see it that
way? How do you decide?
Well,
or is it a problem or not? Am I making up a problem that's not there?
Yeah, it's not a problem.
Okay.
Everybody's tolerance to Iboga varies anyway. So never dose per kilogram, because you can have somebody that takes one little handful of Iboga and they're out there.
Right.
Someone else, and they're going to need like
lots.
7,
Right.
So everybody's body is different. Everybody's mind is different. So that affects your dosing as well. So it really doesn't matter.
So it's really personalized.
It's dosing to effect, that therapeutic window. That's where it is.
And we come back to spirit. So Iboga is a spirit. Iboga has both male and feminine energy in it. And once you take Iboga, and this is in the tradition as well, it stays with you, but it's also something that we have seen. So Iboga just stays with you. You can talk to Iboga anytime you want after.
Interesting.
It will interact with you after. And when people do other plant medicine journeys, Iboga will visit them.
Wow, interesting. Yeah.
It is a master plant. It is like the grandfather or the grandmother. It really is, both in context of like the ideology around the plant of it being a master teacher, but also in its spirit, And really for Gabonese people, it is that tree of knowledge. It is that tree of life. It is that master plant. So, and they value all the other plants in the jungle. It's not like they only use Iboga. They become a true, like a high level person, a Nima, what you would be called. You have to know over 2,000 plants.
Right.
And when you do initiations, they give you Iboga, and then they also give you another plant with it, because they're giving you such high doses of Iboga, they want you to remember your journey. So they give you another plant with Iboga to help you your journey. So, but it's a master plant.
Yeah.
So
what I'm getting a clear sense of is that you are true alchemists for for the spirit, for the soul of a person. And, you're titrating the medicines for that particular personalized, it's the ultimate in personalized medical treatment, really. But it's more than that, because you're not just treating a symptom, you're treating the spirit, the soul of the person. And you do that, I can sense from you, and also who you are, with such competency and respect and honor for both the medicine itself, it's just really beautiful. It's really scaling that particular model. Oh no,
yeah, we're breaking up just a little bit. I'm also aware that I am so enthralled with this conversation. I think we all are, but we've been here for almost 2 hours now. So
okay, we should.
I want to respect everybody's time, and also say that you know, this might warrant other conversations. And if there's questions that people have after, you know, witnessing this dialogue, if they would like to put things in the comments, and we can maybe bring it to folks, there'll be links in the description of the YouTube that just allow you guys to speak to Jeannie and Patrick and Michelle, and also get to know about their work a little bit more. Is there anything that you guys want to share of things that you're moving towards, that you'd like, that you're looking towards, and or you know, things to look out for from all three of your standpoints? And I'll link all those ways to connect to these wonderful humans in the description. But is there anything that you'd like to, some closing thoughts, or something that you're really looking forward to in the next little bit here?
Oh, I think, you know, I think this is such a beautiful conversation, and I think we need more of these conversations. I think we need to be, you know, and I think, Jan, you're so right about there needs to be a paradigm shift around what healthcare really needs. And I think that's the journey. I think that's the journey we're on. And as we move forward, we realize, you know, we get good at something, and then we realize, oh, I understand now its limitations. And so how do I make it better? And I think that's where we're at in the medical field. Like, we've really honed in on very specific skills that are great at acute care. And now we got to go, but what are we missing? And I think it's that deeper healthcare that's beyond, underneath the surface, and that really we've been examining and exploring since the beginning of humanity. And so it's just going to keep evolving. So I think for me, that's, was I supposed to say something more specific, Kim? Like, we have a retreat coming up?
I will link the ways to learn about the retreats that I will be at with you guys, but also I will make sure that that information is below. Of course, first and foremost, it will require a conversation with Patrick and Michelle to see if it's appropriate for you.
Yeah.
But yes, I'll definitely link that. Don't worry.
Yeah, I look forward to experiencing this with you. I'd be honored to have you guide me. I want to thank you for all that you have done in this space, and all that you will continue to do in this space, and for sharing so openly and with such a beautiful heart and soul and intention. I too am working on a couple of fun, hopeful projects. I always go hopeful because you never know, especially in light of what's happening in the States here. But there's a project looking to help fund using Ibogaine for substance use disorder in the Native American community here, starting probably in Arizona, but also including the military, because there's that overlap. So we'll see if
by golly.
Mm-hmm.
We are just having troubles with technology. Sorry, guys.
Cool. Yeah. Anyway, just hoping. Can you hear me now or no?
Yes.
Yeah. Okay, you got that. And then, you know, if I get the opportunity, I've been invited. Maybe it's not quite the right word, but to come to Washington D.C. and explore the possibility of funding psychedelic research. And if that is actually a possibility, and I can use my experiences and thoughts and problem-solving skills to help navigate those very turbulent waters, I'm going to go and listen and see. So, and I want to end on, I feel that my approach to all this is very collaborative, that we need input from the community, but constructive input. Like, how can we actually help and serve one another? So I invite people to email me at, put it in the show notes or whatever you call this, Jeannie Fontana at treathumanity.com. And assess, especially if that opportunity for me arises in Washington, I will definitely throw open the portals to as a collaborative effort. I mean, I want all voices to be heard. Again, focusing on construction, coming together to help serve, not the rhetoric that's oftentimes associated with what the problem is. We know what the problem is. So, yeah. Okay, so thank you.
Thank you so much.
Thank you.
Wonderful.
Oh, by the way, 25 miles. I just rode 25 miles. We're almost home.
Awesome. High five.
Okay. Yeah. Okay. Have a good one.
Thanks,
Okay.
everybody.
Bye.
Hey.
Bye.
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 Bye.